Good morning, dear students. Classification of periodontal diseases. Students, you might be wondering, what does a classification mean? Why do we need a classification? How do we get an ideal classification? What are the various classifications that have been followed till now? And which is the most accepted classification which we are following? Finally, which is the recent classification? So all these questions will be answered in this class. Starting with the introduction, periodontitis is a complex disease resulting in inflammation in supporting tooth structures, leading to progressive attachment loss and bone loss that has no geographic, ethnic, or age barriers. So, classifying periodontal diseases is essential to provide a framework to scientifically study the etiology, pathogenesis, and treatment of disease in an orderly fashion. Classification is defined as a systematic collection of data or knowledge and its arrangement in a sequential manner in order to facilitate its understanding or knowledge. Classification systems can be basically classified based on pathology, morphology, etiology, and topography. Requirement of a classification. It should not be rigid. The classification should be adaptable, it should be consistent, and it should respond to the changing knowledge. A need for a classification. A classification allows for logical and systematic separation and organization of knowledge about the disease so that one may reason from the signs and symptoms in the patient to a presumed etiological history, and from the presumed etiological history we will be able to identify the condition, and then that will finally lead to the prescribed course of the treatment. Uses of classification. Classification helps in the identification of the etiology and understanding of the pathology. It also helps in the diagnosis, prognosis, and treatment planning. It also helps in the facilitation of communication among the clinician, students, researchers, educators, epidemiologists, and public health workers. It also helps in presenting information to the patient about his or her disease. Desirable characteristics of a classification system. A classification system should have a suitable organizing principle matching the nature of the items being classified. Every item should fall into at least one of the classes. No item should fall into more than one of the classes. In the sense, no overlap should be there. It should serve its users, and simpler the classification, the easier it will be to remember and use. So, I hope you guys would have understood about the introduction part of the classification. Now let's look into how the classification system has evolved. The historical development of the classification is mainly influenced by paradigms that reflect the understanding of the nature of periodontal diseases during a given historical period. So it's primarily based on three paradigms. During the 1870 to 1920, we had followed the clinical characteristic paradigm. During the 1920 to 1970 era, we used or followed the classical pathology paradigm. From 1970 till now, we are following the infection or host response paradigm. Clinical characteristic paradigm. In the late 1800s and in the early 1900s, the clinicians used case descriptions and their personal interpretation of what they saw clinically as the primary basis for classifying the periodontal diseases. Little was known about the etiology and pathogenesis of periodontal diseases. These diseases were classified almost entirely on the basis of their clinical characteristics, supplemented by unsubstantiated theories about their cause. So, during this era, the main debate about the nature of periodontal diseases was whether they were caused by local or systemic factors. The drawbacks of clinical paradigm. There was little or no scientific evidence was used to support the opinions of the clinicians of the time. The number of theories about what caused periodontal diseases and how they should be classified and the terminology used to describe them seemed to approach the number of clinicians who treated patients with these diseases. There was no generally accepted terminology or classification system for periodontal diseases was adopted during this era. There was an unclear classification criteria. there was no emphasis on the age of onset or the rate of progression of the diseases. Periodontitis caused by systemic diseases was not included in this classification. So later came the classical pathology paradigm. According to this paradigm, there were two forms of destructive periodontal diseases, that is inflammatory and non-inflammatory, which included the degenerative, dystrophic or atrophic diseases. Basically, the conclusion of this paradigm was based on the overinterpretation of the histopathological studies done by Gottlieb and Orban. Gottlieb had discovered a condition known as cementopathia, which is an impairment in the cementum deposition. He said that this cementopathia was thought to be initiated by the degeneration of the principal fibers of the periodontal ligament that eventually resulted in the detachment of the connective tissue from the tooth, followed by resorption of the alveolar bone. So certain forms of destructive periodontal diseases were due to degenerative changes in the periodontium, and it was later called as periodontosis. This paradigm appeared to explain the perplexing clinical observation that some young patients with relatively clean mouths had massive and localized bone loss with only minimal or no overt signs of gingival inflammation. Drawbacks of this paradigm. It was mainly based on the principles of general pathology. It included disease categories labeled as dystrophic, atrophic, or degenerative. There was no scientific basis for retaining the concept that there were non-inflammatory or degenerative forms of destructive periodontal diseases. The questions were raised on the existence of periodontosis as a distinct disease entity. This term was actually an infection which was earlier thought to be a degenerative change. Later came the infection host response paradigm. Soon after the publication of Robert Koch in 1876, who provided the experimental proof of the germ theory of disease, some dentists began to suggest that periodontal disease might also be caused by bacteria. W. D. Miller was an early proponent of the infectious nature of periodontal diseases. He considered three main factors in every case of pyorrhea alveolaris: predisposing circumstances, local irritation, and bacteria. He advocated that periodontal microflora was complex and no clear group of microorganisms could be causally linked to the diseases. He also advocated certain systemic conditions such as diabetes and pregnancy could modify the course of the disease. So these are the various classifications which are included in the clinical characteristic paradigm and classical pathology paradigm. These are the classifications which are mentioned in the infection host response paradigm. We'll be discussing the last few classifications which is mentioned in this slide, as these are the recent ones. Starting with the world classification given by the World Workshop in Clinical Periodontology in the year 1989. 35 years of age was set as an arbitrary separation of periodontal diseases. In adult periodontitis, the age of onset was greater than 35 years, whereas in early onset periodontitis, the age of onset was less than 35 years. Adult periodontitis had a slow rate of disease progression with no defects in host defenses, whereas early onset periodontitis had a rapid rate of disease progression with defects in host defenses, and it was associated with specific microflora. Early onset periodontitis was later divided into prepubertal, juvenile, or rapidly progressive periodontitis. The various other forms of periodontitis or periodontitis associated with systemic diseases, necrotizing ulcerative periodontitis and refractory periodontitis, which did not respond to treatment at all. So this classification depended on the following factors: the age criteria, the rate of progression, the host response of the affected patient, and other forms which are not responding to the conventional therapy. So what is the merit of this classification? It could be easily categorized based on the age. Demerits of the 1989 classification. It did not include gingivitis or gingival disease category. The periodontitis categories had non-validated age-dependent criteria. Using patient's age as the major classification criteria has few limitations, since the clinical conditions of with same underlying etiology and susceptibility may be classified differently on the basis of patient's age. Next, there is an extreme crossover in the rates of progression of different categories of periodontitis, and there is also an extensive overlap in the clinical characteristics of different categories of periodontitis. So it didn't clearly fit into a single category. For example, a children with a prepubertal periodontitis and with a defect in leukocyte adherence could be included in both the categories, either periodontitis as a manifestation of systemic disease or prepubertal periodontitis. So it could be either of these categories. So it did not clearly fit into one single category. So that's why the overlap was seen. Refractory periodontitis and prepubertal periodontitis were heterogeneous categories. Clear distinction of these categories are not yet evident. Next, moving on to the classification given by the European Workshop and Periodontics in 1993. Based on this classification, the periodontists were classified into three main groups: adult periodontitis, early onset periodontitis, and necrotizing periodontitis. Adult periodontitis, the age of onset was 4th decade, it had a slow rate of progression and no host response defect. Early onset periodontitis had an age of onset prior to the 4th decade with a rapid rate of progression and defect in the host response. Necrotizing periodontitis had a tissue necrosis with attachment and bone loss. The demerits of this 1993 classification were that gingival diseases were not included and it lacked adequate characterization of the broad spectrum of periodontal diseases which are encountered in the clinical practice. Now, we have looked into few classifications. However, there are few drawbacks. It has been observed that chronic periodontal destruction caused by accumulation of local factors can occur before the age of 35 years, and that aggressive disease seen in young patients may be independent of age and instead have a familial association. Next, with respect to refractory periodontitis, causes of the continued loss of attachment and alveolar bone after periodontal therapy are currently poorly defined and they may apply to many disease entities, so it cannot be considered as a specific disease entity. Next, the clinical manifestations of the periodontal diseases which are outlined in the 1989 and 1993 classification were not consistently observed in the different countries of the world, and it did not match the models presented. So, to overcome all the shortcomings of these classifications, AAP in the year 1999 had organized an international workshop for classification of periodontal diseases and conditions to further redefine the classification based on scientific and clinical evidence. So, this is the classification which we are following right now, the AAP classification in the year 1999. So, the periodontal diseases and conditions are classified into gingival diseases, chronic periodontitis, aggressive periodontitis, periodontitis as a manifestation of systemic disease, abscess of the periodontium, periodontitis associated with endodontic lesions, developmental or acquired deformities and conditions. So, now we will be looking into each and every subdivision. First, moving on to the gingival diseases. Gingival diseases are classified into dental plaque-induced gingival diseases and non-plaque-induced gingival lesions. Dental plaque-induced gingival diseases are further classified into gingivitis associated with dental plaque only, gingival diseases modified by systemic factors, by medications and by malnutrition. Non-plaque-induced gingival lesions are further classified into gingival diseases of specific bacterial origin, of viral origin, of fungal origin, of genetic origin, gingival manifestations of systemic conditions, traumatic lesions, foreign body reactions, and not otherwise specified. First is the dental plaque-induced gingival diseases. These diseases occur on a periodontium with no previous attachment loss or on a periodontium that has undergone previous attachment loss and currently received periodontal therapy to stabilize any further disease progression. Under that, first one is gingivitis associated with dental plaque only, with or without the local contributing factors. These contributing factors are basically localized tooth related factors that have the ability to retain the plaque microorganisms and to inhibit the removal of these organisms via plaque control techniques, thereby predisposing the individuals to plaque-induced gingival diseases. So these contributing factors can be like tooth anatomic factors such as cervical enamel projections or enamel pearls, or dental appliances, restorations, root fractures. Next is the gingival diseases modified by systemic factors. Altered gingival inflammatory response to plaque result from the effect of systemic conditions on host, cellular and immunologic functions. They are either associated with the endocrine system, such as puberty associated gingivitis or menstrual cycle associated gingivitis, pregnancy associated gingivitis and diabetes mellitus associated gingivitis, or they are associated with the blood discreases like leukemia associated gingivitis. Leukemia basically affects the immune function by disturbing the normal balance of the immunologically competent WBCs that supply the periodontium, thereby leading to excessive infiltration of the WBCs into the gingiva, thereby leading to gingival enlargement and bleeding. Next is the gingival diseases modified by medications. They are drug-induced gingival diseases which involve drug-induced gingival enlargements and drug-induced gingivitis caused by oral contraceptives. The drug-induced gingival diseases are basically caused by the anticonvulsant drugs such as phenytoin, calcium channel blockers such as nifedipine, and immunosuppressive drugs such as cyclosporin. The development and the severity of the gingival enlargement are basically patient-specific and are influenced by the plaque accumulation and elevated hormone levels. The incidence of gingival inflammation increases with the use of oral contraceptives, and it can be reversed by discontinuation of the oral contraceptives. Next, the gingival diseases which are modified by malnutrition. It includes the ascorbic acid deficiency gingivitis. Basically, it affects the immune function and alters the O's ability to protect oneself against the detrimental effects of the cellular products such as oxygen radicals. So the clinical features of this scorbutic gingivitis is bright red, swollen and bleeding gingiva, as you can see in the picture. Now moving on to the non-plaque induced gingival diseases. We've seen all the plaque induced gingival diseases. Now it is non-plaque induced gingival diseases. Gingival diseases of specific bacterial origin. They involve the sexually transmitted diseases which are caused by Neisseria gonorrhea and Treponema pallidum. The oral lesions can be a result of direct or systemic infection with streptococcal species causing streptococcal gingivitis. It is an acute condition with associated fever, malaise, pain, diffusely inflamed gingiva, red and swollen gingiva. It is associated with group A beta hemolytic infections and it is being preceded by tonsillitis. Gingival diseases of viral origin. Mainly these gingival diseases are being caused by deoxyribonucleic acid or ribonucleic acid viruses. The lesions are related to the reactivation of the latent viruses as a result of reduced immune function. The infection with herpes virus is the most common, causing primary herpetic gingival stomatitis, recurrent oral herpes or varicella zoster infection. Next, moving on to the gingival diseases of fungal origin. They occur more frequently in the immunocompromised individuals, in those with normal oral flora that has been disturbed by the long-term use of broad-spectrum antibiotics under prosthetic devices, in individuals using topical steroids, patients having decreased salivary flow or decreased pH levels and increased salivary glucose levels. So they are basically candidiasis, linear gingival erythema, histoplasmosis and others. Candidiasis are basically infections which manifest as white patches on the gingiva, tongue, oral mucous membrane that can be removed easily with the gauze, and they leave behind a red eroding bleeding surface. Gingival diseases of genetic origin. It exhibits either as an autosomal dominant or as an autosomal recessive modes of inheritance. The most clinically evident condition is hereditary gingival fibromatosis, in which the gingival enlargement may completely cover the teeth, delay the eruption, or it may present as an isolated finding, or it is associated with syndromes. Next, Moving on to the gingival manifestations of systemic conditions. They appear as desquamative lesions or ulcerations of gingiva. They involve mucocutaneous lesions and allergic reactions. In mucocutaneous lesions, you can see sloughing of gingival tissues which leaves painful ulcerations, and autoimmune antibodies are directed at the basement membrane and cleave it from the underlying connective tissue. These mucocutaneous lesions include lichen planus, pemphigoid, pemphigus vulgaris, erythema multiforme, lupus erythematosus, and drug-induced conditions. Next is the allergic reactions. The histological analysis of the biopsies obtained from gingival allergic reactions show a dense infiltrate of eosinophilic cells. They may be allergic to the material in the restorative dentistry, such as mercury, nickel, acrylic, or others. They have a reaction to the toothpaste, mouthwashes, additives in the chewing gum, or other food substances. The diagnosis requires extensive history and selective elimination of potential causes. Next, moving on to the traumatic lesions. Traumatic lesions can be self-inflicted or factitious, caused by the toothbrush trauma, which result in the gingival ulceration or recession. It can be iatrogenic, which is being induced by the dentist when there's an induction of orthodontic cement or restrictive materials into the gingiva. The peripheral ossifying fibroma occurs as a response to the embedment of the foreign material into the gingiva. Or it can be also accidental damage resulting from the minor burns from hot food and drinks. So traumatic lesions can also be classified into chemical lesion resulting from the aspirin burn, or physical lesion resulting from RPDs or oral piercings or improper flossing, or thermal lesions which are resulting from the burns from hot foods and drinks. Next, moving on to the foreign body reactions. The foreign body reaction leads to localized inflammatory condition of the gingiva, which is being caused by the introduction of foreign material into the gingival connective tissue through a break in the epithelium. So following are the various examples wherein there is introduction of amalgam into gingiva during the placement of restoration, or during a tooth extraction, or during an endodontic apicoectomy with retrofill leaving amalgam tattoo, or abrasives which are introduced during polishing. So now we have finished with all the gingival diseases. Now we are moving on to periodontitis. Periodontitis is defined as an inflammatory disease of the supporting tissues of the teeth, which is caused by a specific group of microorganisms, resulting in progressive destruction of periodontal ligament and alveolar bone. So the unique features of periodontitis which are different from gingivitis are presence of clinically detectable attachment loss, pocket formation, changes in the density and height of subjacent alveolar bone, and recession. Periodontitis is classified on the basis of clinical, radiographic, historical, and laboratory characteristics into three main categories, that is chronic periodontitis, aggressive periodontitis, and periodontitis as a manifestation of systemic diseases. Chronic periodontitis. Chronic periodontitis is most prevalent in adults but can occur in children. The age range of more than 35 years that had been previously designated for the classification of this disease is been discarded. Chronic periodontitis is basically associated with the accumulation of plaque and calculus. See, the amount of destruction is consistent with the local factors. It is associated with variable microbial pattern. The subgingival calculus is a frequent finding. It has a slow to moderate rate of progression, but at times it also has periods of rapid attachment loss. The chronic periodontitis can be modified by the following factors, such as systemic diseases, local factors that predispose an individual to periodontitis, and environmental factors such as smoking and stress. These factors actually modify the normal host bacteria interaction, and they also modify the host response to the plaque accumulation. Based on the disease distribution, chronic periodontitis is divided into two main categories. Localized chronic periodontitis occurs in less than 30% of sites, and generalized chronic periodontitis occurs in more than 30% of the sites. Based on the severity, the chronic periodontitis is divided into three main categories. Slight, wherein the clinical attachment loss is of 1 to 2 mm, moderate periodontitis wherein the clinical attachment loss is of 3 to 4 mm, and severe periodontitis wherein the clinical attachment loss is of 5 mm or more. Moving on to aggressive periodontitis. The universal characteristics of aggressive periodontitis is that it occurs in an otherwise clinically healthy patient. There is a rapid attachment loss and bone destruction. The amount of microbial deposits is inconsistent with the disease severity. So it shows that the disease can be severe even at sites with lower plaque accumulation. And there is familial aggregation of deceased individuals. The common characteristics of aggressive periodontitis are the disease sites is infected with aggregative bacteria actinomycetum comitans. There is abnormalities in the phagocyte function, and hyporesponsive macrophages are present that produce increased levels of prostaglandin E2 and interleukin beta. And aggressive periodontitis sometimes have a self-arresting disease progression. Aggressive periodontitis is further classified into localized and generalized forms. In localized aggressive periodontitis, it has a circumpubertal onset of disease. It has a localized first molar and incisor involvement with proximal attachment loss on at least 2 permanent teeth, one of which is a first molar. It has a robust serum antibody response to the infecting agents. In generalized aggressive periodontitis, it usually occurs in individuals under 30 years but does occur in older patients too. It has a poor antibody response to pathogens. It has a pronounced episodic nature of loss of attachment and alveolar bone. There is generalized interproximal attachment loss affecting at least 3 permanent teeth other than the first molars and incisors. Next, moving on to the periodontitis as a manifestation of systemic diseases. This is the diagnosis which is made when the systemic condition is a major predisposing factor and when local factors are not clearly evident. However, in the case in which the periodontal destruction is clearly the result of local factors but has been exacerbated by the onset of conditions such as diabetes mellitus or HIV, then the diagnosis should be chronic periodontitis modified by systemic conditions. The major effect of these disorders is through alterations in host defense mechanisms. The clinical manifestations of many of these disorders appears at an early age and can be confused with aggressive forms of periodontitis with rapid attachment loss and potential for early tooth loss. Periodontitis as a manifestation of systemic diseases can be classified into hematological disorders and genetic disorders. Hematological disorders involve acquired neutropenia or leukemias, and genetic disorders involve familial and cyclic neutropenia, Down syndrome, leukocyte adhesion deficiency syndrome, Papillon-Lefray syndrome, Chidiac-Higashi syndrome, histiocytosis syndromes, glycogen storage disease, infantile genetic agranulocytosis, Cohen syndrome, Ehlers-Danlos syndrome, and hypophosphatasia. So what is this Papillon-Lefray syndrome? Papillon-Lefray syndrome is a rare autosomal recessive disorder which is characterized by diffuse palmar-plantar keratoderma and aggressive periodontitis leading to premature loss of deciduous and permanent dentition at a very young age. It has a mutation in the cathepsin C gene located on chromosome 11q14. As I said before, it has a keratoderma on the palms, soles and knees and a severe aggressive periodontitis. Impaired neutrophil function is considered to be the primary cause of Papillon-Lefray syndrome that results in the deregulation of the leukocyte response to the microbial infection. And many opportunistic periodontal pathogens can be found in the syndrome like Porphyromonas gingivalis, Tanella forsythia, Actinobacillus actinomycetum comitans, Fusobacterium nucleatum, Prevotilla intermedia, and there is also consanguinity of parents, which is a common feature seen in Papillon-Lefray syndrome. Next, moving on to the necrotizing periodontal diseases. The clinical manifestations or the features of these diseases are they have an ulcerated and necrotic papillary and marginal gingiva which is covered by an yellowish white or a grayish slough and pseudomembrane. It has a blunting and cratering of papilla. It has bleeding on provocation or spontaneous bleeding. Pain, fatigue breath, fever, malaise, and lymphadenopathy are the other clinical manifestation. So necrotizing periodontal diseases involves two main diseases, that is necrotizing ulcerative gingivitis and necrotizing ulcerative periodontitis. They're basically the clinical manifestations of the same disease. Just that necrotizing ulcerative periodontitis differ from necrotizing ulcerative gingivitis in having severe attachment loss and severe bone loss. And in both of these conditions, tissue necrosis is a primary clinical feature. So now let's look into the necrotizing ulcerative gingivitis. The defining characteristics of necrotizing ulcerative gingivitis is that it has a bacterial etiology, that is fusiform bacilli and spirochetes are the main reason behind ANUG. It is a necrotic lesion and it has predisposing factors such as stress, smoking and immunosuppression. Malnutrition is also a major contributing factor which leads to immunosuppression, thereby predisposing to necrotizing ulcerative gingivitis. Necrotizing ulcerative periodontitis, the main clinical features are that it has a clinical attachment loss and bone loss distinct from ANUG. It has local ulceration, necrosis of gingival tissues with exposure and rapid destruction of underlying bone. It has spontaneous bleeding and severe pain among HIV patients. So it's basically more or predominantly associated with HIV patients. So HIV patients with necrotizing ulcerative periodontitis usually have 20 times more more likely to have CD4 counts below 200 cells per meter cube. So this clearly shows that immunosuppression is a major contributing factor to necrotizing ulcerative periodontitis. And to treat these necrotizing periodontal diseases, these acute lesions can be treated with antimicrobial therapy, with proper personal oral hygiene care and professional scaling and root planing. Next, moving on to periodontitis associated with endodontic lesions. First among that is the endodontic periodontal lesions. So in these lesions, the pulpal necrosis will precede the periodontal changes. The periapical lesion that originates with the pulpal infection drains to the periodontal ligament, resulting in the destruction of periodontal ligament and adjacent alveolar bone. It also drains through the accessory canals and leads to furcal involvement. It has localized deep periodontal probing depth that extends to the apex of the tooth. It also sometimes has extensive alveolar ridge defect that necessitate a reconstructive surgery before the placement of any kind of prosthesis or implants. Periodontal endodontic lesions. In these lesions, the periodontal lesions will precede the pulpal necrosis. So the bacterial infection from the pocket associated with loss of attachment and root exposure may spread through accessory canals to pulp, resulting in pulpal necrosis. It may also reach the pulp through apical foramen. Scaling and root planing may remove the cementum and the underlying dentin, leading to chronic pulpitis through bacterial penetration of dentinal tubules. Combined lesions occur when pulpal necrosis and periapical lesion occur on a tooth that is periodontally involved. It also occurs when an angular intrabody defect communicates with a periapical lesion of pulpal origin. So, in all these periodontitis cases associated with endodontic lesions, the endodontic infection should be controlled first by a root canal treatment before the definitive management of the periodontal lesion is begun, especially when you are thinking of any kind of regenerative or bone grafting procedures. So, it's better to do an RCT first and then controlling the periodontal infection and then doing the bone grafting procedures. Now moving on to the abscesses of periodontia. It involves gingival abscess, periodontal abscess and pericoronal abscess. So what is the difference between this gingival abscess and periodontal abscess? Gingival abscess is a localized purulent infection which is confined to the marginal gingiva, whereas periodontal abscess is a purulent infection which involves the supporting periodontal tissues. Gingival abscess occur in former disease-free areas. Periodontal abscess occurs in the course of chronic destructive periodontitis. Gingival abscess results when a foreign object is forcefully embedded into the gingiva. Periodontal abscess occurs when there is an occlusion of the orifice of a pre-existing periodontal pocket that prevents the drainage of the purulent material, leading to abscess formation. So the clinical features of gingival abscess is a red swelling with a smooth, shiny surface. Within 24 to 48 hours, the lesion becomes fluctuant and pointed with a surface orifice from which the purulent exudate is expressed. The adjacent teeth are sensitive to percussion. So if you leave it to progress, it will just rupture spontaneously. Whereas the clinical features of periodontal abscess are ovoid swelling of gingiva, pain, tooth mobility, tooth elevation, suppuration, and deep pockets. The gingival abscess can be treated by incision and drainage and irrigation, whereas the periodontal abscess should be treated by incision and drainage, irrigation along with pocket elimination procedure. So how do we diagnose whether it's a periodontal abscess? First, by asking a dental history from the patient. Whether they have had any previous periodontal abscesses, they've undergone any previous periodontal treatments or endodontic therapy. Because treatment of patients with advanced periodontitis conditions with just antimicrobials and without any subgingival debridement will lead to abscess formation. Even during scaling, the calculus might get dislodged and get pushed into the soft tissue, leading to abscess formation. Periodontal abscess formation can also form due to inadequate scaling, which allow the calculus to remain in the deepest part of the pocket, while the resolution of inflammation at the coronal pocket area will occlude the normal drainage and the orifice of the pocket, thereby leading to the entrapment of the subgingival flora in the deepest part of the pocket. Sometimes lateral perforation of the root during the endodontic therapy can also cause periodontal abscess formation. Next, clinically, we can determine by probing the suspected area. If there is a continuity of lesion with the gingival margin, then it clearly shows that the abscess is of periodontal origin. Radiographically, you can see a discrete area of radiolucency along the lateral aspect of the root. Lesions in the soft tissue wall of the periodontal pocket are less likely to produce the radiographic changes. Finally, moving on to the pericorneal abscess. Pericorneal abscess is a complication of pericornitis, wherein you can see an inflamed pericorneal flap covering the disto-occlusal surface of the impacted molars. It spreads posteriorly into the oropharyngeal areas and medially to the base of the tongue, causing difficulty in swallowing. Now we have come to the last part of the classification, developmental or acquired deformities and conditions. Under that, the first subclassification is localized tooth-related factors that modify or predispose to plaque-induced gingival diseases or periodontitis. They involve tooth anatomic factors, dental restorations or appliances, root fractures, cervical root resorption, and cemental tears. Tooth anatomic factors are basically malformations in the development of the tooth or in the tooth locations. They are associated with increased plaque accumulation, attachment loss, bone loss, furcal involvement, especially when they are combined with poor oral hygiene habits. So the main tooth anatomic factors which predispose to periodontitis are cervical enamel projections, which are predominantly found in maxillary and mandibular molars, enamel pearls, palatogingival grooves, which are predominantly found in maxillary incisors, proximal root grooves, which are predominantly found in the maxillary premolars, bifurcation ridge present in the mandibular molars crossing from the mesial to the distal root at the midpoint of the furcation, malaligned tooth, and open contacts which favor food impaction, thereby leading to increased bone loss. Next, moving on to the dental restorations or appliances. The subgingivally placed onlays, crowns, fillings, and orthodontic bands may impinge on the biological width by being placed deep in the sulcus or within the junctional epithelium. Thereby, it promotes the inflammation and loss of clinical attachment and bone with apical migration of junctional epithelium. Root fractures caused by traumatic forces or by endodontic procedures may lead to periodontal involvement through apical migration of plaque along the fracture line. Avulsed tooth that are replanted may result in cervical root resorption or cemental tears. These may in turn lead to periodontal destruction when the lesion communicates with the oral cavity and allows the bacteria to migrate subgingivally. Next, moving on to the mucogingival deformities and conditions around the teeth. That is the gingival soft tissue recession, lack of keratinized gingiva, decreased vestibular depth, aberrant frenum or muscle position, or gingival excess. This involves a pseudo pocket, inconsistent gingival margin, excessive gingival display, gingival enlargement, or abnormal color. Next, moving on to the mucogingival deformities and conditions on the edentulous ridges. That is the vertical or horizontal ridge deficiency, lack of gingival keratinized tissue, gingival soft tissue enlargement, aberrant frenum or muscle position, decreased vestibular depth, and abnormal color. Finally, the occlusal trauma, which predisposed to periodontitis. Occlusal trauma is a tissue injury that results when occlusal forces exceed the adaptive capacity of periodontium. When the tissue injury is caused by alteration in occlusal forces, it's called primary trauma from occlusion. When it is caused by reduced capacity of periodontium to withstand the occlusal forces, then it is called secondary trauma from occlusion. So primary trauma from occlusion occurs around teeth with healthy periodontium. For example, when there is any high filling placed or when there is any insertion of processes that creates excessive forces on the abutment and on the antagonist teeth, or drifting movement of teeth into spaces created by unreplaced missing teeth, or any orthodontic movement of teeth into functionally unacceptable position. Whereas in secondary trauma from occlusion, it occurs around teeth with reduced periodontium. That is, it usually occurs in periodontitis cases wherein the periodontium becomes more vulnerable to injury, and it is previously well tolerated occlusal forces becomes traumatic. So what are the changes which is made in the 1999 classification which we have seen so far? That is different from the previous 1989 classification and 1993 classification. So what's so unique in it? What is the characteristic features of this 1999 classification? So there's been an addition of section on gingival diseases. There's replacement of adult periodontitis term with chronic periodontitis. Replacement of early onset periodontitis term with aggressive periodontitis. There's elimination of separate disease category for refractory periodontitis. Clarification of the designation periodontitis as a manifestation of systemic diseases. Replacement of necrotizing ulcerative periodontitis with necrotizing periodontal diseases. Addition of a category on periodontal abscess. Addition of a category on periodontal endodontic lesions. Addition of a category on developmental or acquired deformities and conditions. So we have seen the merits of the classification. So what are the limitations of the 1999 classification? Understanding of periodontal disease is not complete enough to base our classification on etiology. It depends upon assessing the rate of progression spread over multiple appointments in order to diagnose aggressive periodontitis. So it is not possible to call our patient for repeated visits to just place him or her under specific disease entities such as aggressive periodontitis or chronic periodontitis. No provision in the present classification for the diseases around implants, leaving a very significant void. And all the risk factors such as smoking, diabetes mellitus are not considered in this classification. Now, at present, that is, the classification of periodontal and peri-implant diseases and conditions has been proposed in the year 2017. This was developed in order to accommodate advances in the knowledge which is derived from biological and clinical research that have emerged since 1999 classification. So what is the highlights of this 2017 classification? It defines the clinical health for the first time and distinguishes an intact and reduced periodontium. The term aggressive periodontitis was removed, creating a staging and grading system for periodontitis that is based on the attachment and bone loss, and it classifies the periodontal disease into 4 stages based on severity, the stage 1, 2, 3 and 4, and 3 grades based on disease susceptibility, that is grade A, B and C. It has identified the difference between the presence of gingival inflammation at one or more sites, and it also given a definition of gingivitis case. It has agreed that the bleeding on probing should be considered as a primary parameter to set threshold for gingivitis. It has characterized periodontal health and gingival inflammation in a reduced periodontium after completion of successful treatment of a patient with periodontitis. It has also reorganized the broad spectrum of non-plaque induced gingival diseases and conditions based on etiology. So, the main features of this 2017 classification is that there's been staging and grading in periodontitis. So, staging intends to classify the severity and extent of a patient's disease based on the measurable amount of the destroyed or damaged tissue as a result of periodontitis. So, it has been determined after considering various variables such as clinical attachment loss, amount of bone loss, probing pocket depth, presence and extent of angular bony defects, tooth mobility, and tooth loss due to periodontitis. So, this is the various stages of periodontitis, stage 1, 2, 3 and 4. Grading. Grading structure considers supplemental biological characteristics of the patient in estimating the rate and likelihood of periodontitis progression, such as patient's overall health status and patient's smoking habit and metabolic control of the diabetes. So, it aims to indicate the rate of periodontitis progression, responsiveness to the standard therapy, and its potential impact on the systemic health. So, students, we have come to the end of the class. I hope you would have understood the various classification systems that we are following and the importance of a classification system. So, thanks a lot for your patient listening. Kindly fill in your assignments and submit your assignments within the stipulated period of time. Thank you, students.